Excellent. All right, thanks. So I'm the director of the Bakar Computational Health Sciences Institute at UCSF, which is a very similar institute to what you're launching now. But we're about 8 years in. So I'm going to talk about what we've been doing for the past 8 years. And then, so that's at UCSF. We also have a structure across the entire University of California, which I'll spend most of the time talking about. What happens when you go beyond just one academic medical center with all the different types of data that are out there. First of all, I'm a medical doctor, so I got to start with my conflicts of interest. I have just a few. Suffice it to say, I've started a couple companies. I consult for a whole bunch of companies. I wouldn't blame you if you didn't believe another word I said over the next hour. But I'm really proud of the right side here, all the companies started by my students. More than half my grad students now start companies, even if they go into academia. And they do this with the most amazing platform in the world. It's simply data. It's often open data. It's certainly big data. I'm going to show you how they do it. I'm going to show you how I do it. And maybe I'll convince you this is still the most amazing time to be in biomedical innovation and even entrepreneurship. And don't forget entrepreneurship in these institutes, because the world needs what we're building. As I say in my lab all the time, if you want to change the world, you can't just keep writing papers about it. If you've invented something or discovered something, you have to then find someone to license it. If no one's licensing it, it's up to you to start the company. So we definitely take that to heart in my lab, in my institute. All right, so you can't help but pick up any magazine. You'll see a cover like this, data, AI, machine learning. You know it, we all know it. That's why you have an institute here. In fact, The Economist covers it again and again, the data deluge. And now, on the right here, suggesting that data is the most valuable resource. Now, it's a very interesting cover because they're showing oil rigs. And thus, we have this saying that people say that data is the new oil. I hate that saying, okay? Because oil, especially in California, we know oil comes in barrels. And the thing about barrels of oil is either I have that barrel or you have that barrel, right? And data is not like that. I can take data and build something magical with it. You might take that same data and build something differently magical with it. So the saying I like that comes from yet another one of these TED Talks is data is the new soil, right? You plant your ideas and data will help them grow, will nurture that, right? So it's not grabby, either I have the data or you do. Everyone has that data. You can do different things with it. And certainly we have all the logos in biomedicine too. We are drowning in biomedical data. I think we have plenty of data sets now. Now, I'm not going to say not to create more, but not only are each one of these repositories growing exponentially, the number of repositories is growing exponentially now. Of course, there's NIH mandates and all that we've talked about earlier this morning, but it's been happening now for the past 10 to 15 years. And you can see some of your favorite logos there. For some of the trainees in the audience, I'll highlight a few of my favorite ones from this panoply of logos. Just to give you some examples, the Cancer Genome Atlas is a great database. 84,000 cases of cancer from all over the country, all over the world, of 68 different kinds of cancer. And it's not just gene expression, not just DNA, it's 22 types of data, right? Many omics data sets, right? So you got proteomics, reverse phase, lysate. You sort of have DNA sequencing, so oncogenes, RNA, but also clinical data, right? So you even have the survival with drugs that were treated on, and even mammographies, head CTs, and they give this data away to you, right? That's just one of those repositories. Another of my favorite is PubChem. Most people never heard of PubChem. They've heard of PubMed. This is a next door neighbor run by NCBI. PubChem comes out of the fact that many of our universities now want to screen cells to see if there's any drugs out there, right? So if you get a cell, let's say that's glowing if it's living or glowing if it's dying, once you got that kind of cell made, you can use robots to test a whole bunch of drugs to see if any of them are going to help make that cell live or die, depending on what you want it to do. But if you got an NIH grant to do that, you got to deposit all that data into PubChem. And so this is how academics now are screening for drugs, a similar way than how biotechs or drug companies are doing this. What is PubChem now? If you just think of it as a big grid of 250 million substances already tested, those are the columns, 1.2 million bioassays already run, those are the rows. So if you do that math, that's 344 trillion little boxes, of which 272 million of them have been tested. So this substance and this screening assay, this substance and this screening assay, okay? Already done, already available. Now, of those columns, 71 million of them meet something called Lipinski's Rule of 5, which means that could even be an oral drug someday. It doesn't even have to be IV, it can be an oral drug. And of the 272 million measurements, 1.2 million of them were active, meaning the researcher who ran the study said this drug worked in that assay. Now, I can easily bet you a beer, this beats any pharma company, okay? In fact, I can bet you a nice bottle of wine, this beats them all combined, because this is still doubling every 2 to 3 to 4 or 5 years, and very little in pharma drug discovery is doubling every 2 to 3 to 4 to 5 years anymore. And they give this away to you without a user ID and password, right? Literally every small molecule drug probably we're ever going to have in the next 20 years is sitting there as a column in this grid waiting for you. If you don't download this data and look at these columns, nobody's going to do it, right? How many drugs are just sitting there in this grid waiting for you? That is literally the whole story here. Another great data set that was mentioned earlier today, well, the UK Biobank was mentioned. Let's mention the US version, the All of Us Research Hub. Of course, a number of Californians in this data set, but all over the country. Over 500,000 participants on their way to 1 million. This is building our version of the UK Biobank, but with the race and ethnicity. And all the underrepresented folks, all captured now in the All of Us Research Program. This was launched by President Obama. 355,000 of those folks have completed initial steps. 550 have at least signed up, and now DNA is being acquired. DNA is being whole genome, I think it's exome sequence, probably whole genome sequence getting released to participants, but all the clinical data on these folks now, right? Coming from medical centers, going into the research hub that you can start to do clinical studies. The data is sitting there waiting for you. I'm a big fan of the next big open data. I think this is gonna happen in a hurry. Clinical trials data. If you haven't seen, the world doesn't really trust pharma biotechs anymore. I'm not saying that's a good thing. I'm just calling it like I see it. I can see the world having to demand more clinical trials data, whether it's vaccines or something else. I'm really proud because we run this one called Import, which is a lot of immunology and autoimmune drug trials. And it's not a sandbox. You can literally download data. I think that's going to be the next fun big thing, is to figure out clinical trials and reanalyzing someone else's trials data to see what exactly did they find, especially the failed trials. We don't release enough of those to learn new science. So we're really happy to run this one with Paraton and a whole bunch of others, releasing raw clinical trials data. But what are we going to do with all this data is try to get to precision medicine, right? And it's been now 12 years since we've had this phrase, precision medicine. It's 2011 when the National Academy of Medicine report came out, and President Obama launched that. It's a glorious report. It's still relevant today. I recommend you read it, but it's over 100 pages. But to me, it comes down to this one figure, to precision medicine, right? Precision medicine is we're trying to customize the medical care we're going to deliver to a patient based on measurements from that patient that we're going to compare to many others. It's not just DNA, it's not just proteins, it might be your behavioral measurements, it might be your preferences. I don't want that side effect, I can tolerate this side effect. But we compare that to a database. But to build that new world, it comes down to these 3 circles, okay? 100 pages of glorious report in one figure. We need better diagnostics, we need better treatments, we need to figure out our health outcomes, okay? So the rest of the whole talk is how we're gonna use all this data we have to come up with better diagnostics, better treatments, and really the hard part is figuring out our health outcomes. Of all the things we do in medicine, what is actually working and not working, right? Every single day, every single patient, how are we gonna learn from all of those here? So I'm going to start with some diagnostics and then get to therapeutics and then get to the health outcomes, which is the new kind of fun part here. Well, let's talk about diagnostics for a second. What is a diagnostic, right? A diagnostic helps a doctor, nurse, healthcare provider decide if you have a disease or a condition or not, right? So we might have imaging diagnostics. We heard about CTs and PET scans. I love blood tests. I love serum proteins or plasma proteins, and because it's seemingly precise. We can measure that from the blood. And so we wanted to come up with a reliable way to get to diagnostics. And we've started with this disorder called preeclampsia. Now, this is not a rare disorder, but it's amazing how few people have actually heard of preeclampsia. The few of you that might have watched Downton Abbey when it came back, one of the characters dies of eclampsia. Spoiler alert if you haven't seen it. It's already kind of old now. But preeclampsia is when the blood pressure for a pregnant woman goes shooting high, and it endangers the mom, it endangers the baby. Then the baby usually has to come out early. We pediatricians then have to take care of these tiny little creatures for months, keeping them free of infection, their heads and their brains healthy. A lot of mortality, a lot of morbidity. Every socioeconomic status, every ethnicity, race in the world has a problem with preeclampsia. But the test for this is ancient. It's urine protein, okay? Not even a specific one. We just look at urine protein. We said, let's come up with a blood test for this because there's a lot of folks with urine protein now in today's obese American world. Why don't we come up with a more specific blood test? And so how do we do this? Well, we literally, in those databases I just showed you, we literally type in preeclampsia and we download every database we can, right? Especially gene expression, protein measurements, and we start to do a Venn diagram. I'm not gonna show you any math, I'm not gonna show you any code. Imagine downloading all these data sets to figure out what everyone has in common. Right? I don't care if that researcher found it or this researcher found it. If both researchers found it, then I'm really interested. And if 10 researchers found it, I'm really interested. I'm gonna make that my blood test. And so here's an example. Linda Liu, Bruce Ling, and Matt Cooper were involved with this work. Linda was a grad student. And here's one of a whole panel of tests we came up with. This is a protein called hemopexin. As you can see, we got samples out of a freezer. We tested it. Then the women who had preeclampsia as they were delivering had a higher measurement than those who were pregnant without that measurement, no matter where in the gestational age it was. And we found a whole dozen of these. We downloaded open public big data, turned our crank, got some proteins, tested with some samples. We got some grants to do this when this was back in my Stanford days. March of Dimes, Spark, it's our CTSA, gave us some seed funding. We wrote some papers on it, but what do you do next in Silicon Valley? You start a company on this. And this became a company called Carmenta, because the next step is to do a prospective trial, right? Here's the point, okay? The science continues in the startup companies, right? The next experiment now, we showed this on our benchtop, is to do a prospective clinical trial with some of these markers. But that science experiment now will be funded by private dollars. So here's the arrow. You'll see a couple of these. Unmet need, data available. Had the March of Dimes money. We designed the diagnostic CTSA money to test the samples in a freezer, launched the company, and immediately got $2 million in seed financing. Now, I'm not showing you $2 million to brag about it. As you know, that's not a lot of money to raise, actually, in Silicon Valley. But what I'm trying to convince you is that the science continues in the startup companies now funded by private dollars. Or to put it another way, do you know how hard it is to get a brand new $2 million NIH grant? The science continues in startup companies. There's nothing wrong to talk about companies at an academic institution. Okay, now we got $2 million. We launched the study, and I love this story because the company already got acquired. Okay, now some of you know what that means. So we went from downloading data to designing the diagnostic, testing samples off the freezer, out of the freezer, spinning out the company, selling the company, start to finish, 18 months. Okay? Inventors happy, investors happy, university happy. Of course we can do more of these, and I'm giving away all the secrets here. Because every one of you could pick a different diagnostic. We'd never step on each other's toes. That's how many diagnostics we still need in medicine. Every secret I just gave you, it's all on the links here. It's all public what we did here. All the papers are open access. We were able to sell the company to a company called Progenity, which then had its own IPO. That's the first story. Another diagnostic, DNA sequencing. When I was in training not even that long ago, it was a miracle we could get the entire human genome sequence in factory-like settings like the Whitehead Institute, which is this picture. And now literally this is my hand holding a USB stick sequencer, right? This is Oxford Nanopore. Now, it's a no-brainer we're gonna be sequencing more and more in medicine. It might not be healthy folks, it's certainly gonna be cancers, there's gonna be a lot of diagnostic odysseys coming to an end with rare diseases. And I'm not even saying every exam room's gonna have a sequencer or every clinic, but it's a no-brainer. We're gonna need to, and we're gonna be using more and more sequencing. Now, I'm not a geneticist. I got my start, though, in sequencing because of this patient who showed up at Stanford, this was 12 years ago, named Steve Quake. Now, he's a very unusual patient. He's a bioengineer who starts sequencing companies on the side. He was one of the first faculty to get his genome out there back in those days. Those were the kind of papers out there. And then one day, here's Steve, and this is his nephew. His nephew, at age 19, died of sudden death. Did not wake up one morning, cardiac event. And so Steve went to his cardiologist, our good friend, Ewan Ashley, said, well, doctor, am I gonna die of sudden death? And doctor, here is my genome, okay? Some of you still chuckling because 10 years later, if someone did that to us, we'd still not know what to do. So this paper became a prototype of what it was gonna be like for a doctor to get a genome in an exam room someday, right? Now, this also is the work, we had a number of authors on this paper. This is one of the most highly cited papers in Lancet that year. Most highly cited paper in all of biomedicine, actually, that year. But we had such an author list that this is where they came up with the phrase $1,000 genome, $1 million interpretation, because of all the people needed to analyze this. Now, you and Ashley could give you an hour-long talk. He's written a book on this. It's a great book. It's available on Amazon, of course, like everything. And the long story short is Steve Quake does not have any known mutations in any known genes to set him up for a cardiac arrhythmia. Okay, so that's good. Russ Altman could give an hour-long talk on pharmacogenomics, 150 drugs we can say something about now with the genome sequence, right? Is the drug going to work? What could the side effects be? What could the dose be, let's say for warfarin or all the rest? That could be an hour-long talk. Now, the heart was done. The pharmacogenomics was done. My lab was stuck with all the rest of medicine, okay? And every other disease, every other condition. And so I'm going to show you how I did this and how we did this, because what we realized in 2008, because we had found philanthropic dollars, because we really knew the future was coming, we started to look around for databases that we can actually compare to a human genome. We knew a patient was going to show up someday. Were we ready to go with databases of all the different spots in the DNA, all the SNPs, and all the diseases? We realized there was no good database, so we literally started to manually curate every single paper in genetics. We literally started with a high school kid from San Jose, gave him 50 papers to read that summer, and this is one of the papers he read, and we realized, if a high school kid can read a genetics paper and curate it, then there is some hope for just scaling up. And this is what I mean by curating. This is what a typical genetics paper looks like. The data is still buried in tables, and they're sideways. You can't even copy-paste these things, right? But from every paper, we started to record 100 different things. Was it a genome-wide association study or post-GWAS? What disease, what phenotype? All the different populations. We had 800 ethnicity codes we had to invent because of all the different subpopulations. Every single number from every single table was written down. We mapped it all to standardized concepts. Well, if a high school kid can do 50 in a summer, we realized that we want to just read them all. So here's 6 papers, here's 100 papers, here's 1,000 papers, and I literally have a Python script that makes this from the PDFs, and we end up reading 20,000 papers in human genetics manually. Every supplement, every table, every figure, manually. Now, we hired a massive team in India to do all of this, 200 geneticists, bioinformaticians, to just read every single paper in genetics, and we got it done. We got every single one. We have the master list of every SNP, it's only money at a certain point. You can do this, right? If this is the vision you give to your donors, that this is how you're going to change the world, it's only money, okay? We had the dollars to do this. We read the entire world's literature in genetics. Now, with that, in 2010, we realized we could start to give some advice to patients like Steve Quake. And so here's the kind of data viz we came up. This is already 12 years old, but what we say is it's not enough to talk about this SNP and this mutation. What we realized is let's make the font size higher, bigger, if that's the disease that he's set up to get. And diseases cause other diseases. So just because you're not at genetic risk to have hypertension, if you end up with obesity, you could still end up with hypertension, right? We keep forgetting that one disease can cause the other disease, right? So there's causality here. And all around the edge here are all the known environmental factors that can influence you getting these diseases, right? So, and we mined the heck out of PubMed to do this. So you can see our advice to Steve Quake was, don't smoke, watch your alcohol, watch your stress, you should exercise. Probably don't need a genome sequence for those 4, I admit, okay? But in tiny font at the top, if you zoom in, you see pesticides linked to Parkinson's disease. We didn't make that fact up, it's in PubMed, but he's at slightly higher risk for Parkinson's, so we could say, Steve Quake, stay away from the pesticides if you love to go gardening here, right? And so I think this is the future prescription pad of the future, right? Let's say a genome-enabled way to influence behavior. It's a testable hypothesis. Whether having this influences that behavior, it's damn hard to change behavior. I get it, okay? So one could think about that, study that. But I think all of these font sizes will keep changing as you get older, right? Every time you come in, you're gonna get lower risk to get those childhood things, higher risk to get these adult things kind of thing, right? So we did this, we then turned this crank like crazy with a whole bunch of others, and what do you do next in Silicon Valley? This ended up becoming a company called Personalis. And so they have the contract now to do this kind of sequencing for the Million Veterans Program, which is a major national effort. Of course, they pivoted right away to cancer sequencing, which is the biggest area right now in precision medicine. And after raising, I think probably $200 million with Series A, B, and C, we IPO'd 3 years ago, and at market peak, we reached a $2 billion company valuation. Or to put it another way, do you know how hard it is to get a $2 billion NIH grant? The science continues in the startup companies. You're going to hear me say this again and again. Do not ignore entrepreneurship. If you want to scale and reach and touch those patients out there, don't just keep writing papers about it, okay? I don't know how many students and postdocs were involved in my lab, and as well as the lab is Ewan Ashley, Russ Altman, and Mike Snyder, okay? Probably 50 students and postdocs involved. 50 disclosures end up getting licensed into the company here. Now, of course, nothing's worth $2 billion anymore. If you heard biotech has kind of melted down, so be it. Time to start another one. All right, one more shorter story, and then I'll talk about the fun new stuff. Those are diagnostics. What about therapeutics, drugs? Boy, it's getting harder and harder to make a new drug. Now, everyone has heard the saying, everyone thinks it takes $1 billion to make a new drug. Now, this is even old data, but Matthew Harper used to count the dollars every couple of years in Forbes. And you know, it's really simple math. I know we haven't had lunch yet, but here's a simple math. How do you tell how much it costs to make a new drug? How much did you spend, divide by how many drugs did you get, right? Simple math. How much did you spend, divide by how many drugs you get? If you do that simple math, you realize even 10 years ago now, it was already costing between $4 and $12 billion per drug for these top 12 companies here. Probably not sustainable. Now, I'm not going to pass judgment. You may love the pharma industry. You may hate the pharma industry. I'm not going to pass judgment. But we cannot keep having it cost $12 billion to make a new drug, right? That's going to be insane. So we need to, we've got to come up with new efficient ways to do this. Can't we use all that data I just showed you with PubChem and all the rest of these? That was the kind of trick. And so let's download all this data. There's so many people studying diseases, so many people studying drugs. Let's put those two together and see if there's a match. Now, we turned this crank of computers, and you can do all sorts of matching, and lots of algorithms for that. Where we had a lot of fun weren't the new drugs, but were the new uses of old drugs, right? Drug repositioning has gone on for many years, and what we realized is we could figure out new uses for old drugs with this kind of way. We published 15, 20 papers on this. This was the last one we published because we're not going to do this kind of thing anymore. This is one of my favorite examples. This is a condition called liver cancer, hepatocellular carcinoma. Now, hepatocellular carcinoma affects 350,000 people every year in the world, but very, very few in the United States. It's mostly India and China. Now, I'm not saying cause or effect. We don't have a bunch of pharma companies working on hepatocellular carcinoma. We don't have a lot of Americans getting it. It's a fact, okay? We just don't have a lot of companies. Well, here, if we turn our compute crank with open data, we get this winner of nicolosamide. Now, I know people are talking about horse drugs and COVID and all that. This is a worm drug. You give it and it gets rid of worms. You can use it for pets as well, okay? And so here is a mouse implanted with human hepatocellular cell line, and you can see the nodules there. Boy, nicolosamide doesn't look any better, I admit. NEN is nicosamide ethylolamide, a particular salt form of it that the mouse can eat orally, okay? And you can see it kind of looks pink and healthy. That looks better. Glowing cancers are smaller with NEN, that's good. And here, we tested it with the only other existing drug out there called sorafenib, which happens to also be a UCSF molecule licensed to Onyx. Here's nothing, doing nothing. NEN shrinks the tumor. Sorafenib is the existing drug, also shrinks the tumor. But when you give the two together, it actually shrinks it even more, meaning that this might be some synergistic effect here. So if we're going to launch a company or launch a trial, we'd probably partner NEN with the existing drug sorafenib. So now here you have a cancer that affects a bunch of people in the world that very few pharma companies are working on. And here is an example of just one of those stupid little columns in a PubChem, right? All of this data is sitting there waiting for you. If you don't do this as the data scientists, the biomedical data scientists of the future, nobody's going to do this, let me tell you. Because the rest of the world just keeps generating data, okay? So few people using the data already there. Don't wait for the perfect data. It's great data as well. Well, what do we do with this in Silicon Valley? We started a company on this, and this became NewMedi. And after raising, I think, close to $10 million now, they're focusing on idiopathic pulmonary fibrosis, which is a nasty condition in your lungs. They just start to fibrose by itself. And there are already 2 existing drugs. Neither are really great for long-term. Patients don't like the side effects, pretty bad side effects. We think we might have a brand new molecule there as well. So that's what we've been doing. And that's great for the molecular world and the cellular world. But what to me is the next big data? Electronic health record data. Now, you started to hear about electronic health records a little bit, but let me just illustrate how expensive this data is. Here are 3 press releases, okay? Press releases of different health systems installing electronic health records. Sutter, which is one of our California-based systems, they're our frenemy, they're our neighbors, but they're competitive health systems, spent $1 billion on their electronic health record system, $1 billion. Partners, which is Massachusetts General and Brigham and Women's Hospital, and their 40 or so affiliates in the Boston area, spent $1.2 billion on their EHR system. And then Kaiser Permanente spent $4 billion on their EHR system. And amazingly, they all bought the same system, Epic, which is what you use, is what we use, okay? I call this now the most expensive data in the world. This isn't even the expensive part. We pay doctors to type all of this stuff in right now, okay? And so the narrative, the key narrative I want to make sure you leave my talk with is, given the hundreds of billions of dollars we've collectively spent collecting this data, it will be a national tragedy if we don't use this data to improve the practice of medicine, right? It's a no-brainer. Hundreds of billions spent here. What a tragedy it'll be if we don't use this to improve the practice of medicine. Of course, we have to do it safely, responsibly, respectfully, but what a tragedy it'll be if we don't use this data to improve medicine. That is really the whole punchline here, right? You're sitting on a lot of data too, I know that. You gotta use this, because if you don't do this, nobody's gonna do this. So let me introduce what we're doing with EHR data by reintroducing the University of California to you. So University of California is enormous. We have 10 campuses, 3 national labs, including Lawrence Livermore, which has, I think, the number 2, maybe number 1, number 3 supercomputer in the country now. 200,000 employees, so we're one of the larger employers in the United States, 250,000 students per year, and we have 20 health professional schools, so 6 medical schools, and then 14 others, nursing, pharmacy, dental, veterinary, public health schools across the state. We train half the medical students and residents in California, so even if they don't stay with us, we still have some influence. We've got about $2 billion in NIH funding. We make about $13 to $14 billion a year just seeing patients. 5,000 doctors get a paycheck every month from us, but 100,000 doctors write orders on our patients every year. 100,000. That's all the residents and fellows. 12,000 nurses. And US News, and we're not just shabby organizations, right? UCSF and UCLA are in US News top 10. Now, I only say this because we're in the top 10 now. In fact, we're getting higher because others are leaving. I'm not sure if we're going to leave. We're still there, but our numbers are going up. So I don't know. I'm not sure what our incentive is anymore, but I get that. I'm only going to mention this while we're in the top 10, but it's still there. And then we got these, we got 5 NCI comprehensive cancer centers, 5 CTSAs. They're independent, but they obviously work together, as I'll show you in a moment. And then we got these secret superpowers that are so secret, even our faculty forget we have them, okay? IRB reliance. If any of our IRBs approves a study, the others automatically approve it, okay? So we can scale a trial. So what does that mean in reality? Instead of weeks to months, it'll take days to weeks, let's say. And then centralized contracting. So if you, for example, if any of our contracts are signed by the UC Office of the President, all the campuses agree and no renegotiation. So we can scale contracting, we can scale studies pretty quickly. And now we have this umbrella across the entire health enterprise called the University of California Health, UC Health. And that's what beyond the UCSF side, that's the other part of my job here. Now, UC Health really came about because we really wanted to start to organize the health systems to actually start to practice medicine together. And our aspiration, and it's an old aspiration now, but still there, is to create what's called a single accountable care organization for the entire University of California. An accountable care organization means that we're paid a certain per member per month. Think of it as Netflix. I mean, most people don't know how healthcare is paid for. Think of it as Netflix, right? You paid a certain amount, you can do whatever you want on Netflix for that same amount, right? That's healthcare too. at this level. You pay the same amount, no matter what happens to be needed for you, it better all collectively fit in this dollar amount. So you're paid per member per month, but anything that goes right or wrong, you're gonna be on the hook for. So there are a lot of ways to do this wrong and bad, right? To lose money in a hurry. So we partner with United Health to actually learn how to take on risk. Again, I am not gonna pass judgment on United Healthcare, okay? United Health Group, you may love them, you may hate them, I'm not gonna say anything more. We signed an agreement and we have a 10-year aspiration to build a single accountable care organization. Fine, that's good, that's business. Now all of a sudden, the next question comes up. Well, UCLA kind of does it this way and UCSF kind of does it that way. What's the right UC way going to be to treat everything, right? Lung transplants, liver transplants, kidney transplants, this cancer, diabetes. What is going to be the UC way to treat anything and everything? Because we're not sure which is the right way to do it. And boy, when you have that question, it really helps to have all the data in one place. And that is what we have. So we have now a centralized data warehouse of all clinical data from all of those campuses that gets centralized every 2 to 4 weeks, okay? It's all cloud-based, and let's talk about that in a moment. Here are the logos. So UCSF and UCLA are the two big gorillas. They're the big ones. UC Irvine, UC Riverside are a little bit smaller in their markets. UC Irvine and UC Davis are smaller ones. UC San Diego is medium-sized. And Riverside is a baby sibling. It's just a medical school, no hospital there yet. They have partner hospitals there. So 5 of them are massive. Riverside is tiny, but we're still going to show them just like anyone else here. And now all of that data rolls up centralized. They all do their own thing, but they also have the centralized version too. All right, so here are the details. This is as of a couple days ago. So we got UCSF, UCLA, Irvine, Davis, San Diego, Riverside. We installed Epic back in January of 2012. So now we have 11 years of data in Epic. Okay, at least at UCLA and UCSF. Irvine was the last one to come online. So we have structured data now from 2012 forward, so what's that, 11 years. We're just coming up on 9 million patients with this kind of modern data. I know I'm putting the word epic and modern in the same sentence. Please excuse that. But what it means is every dose of every drug, every vital sign, every pain score, every lab test result for nearly 9 million patients. Here are the actual numbers. We're coming up on 1/3 of a billion encounters, 1 billion procedures we've done, 1.3 billion medication orders or prescriptions, that's my favorite, 45 million devices used, 1.4 million doctors have cared for all of these patients going back 11 years, 1.1 billion diagnosis codes, more than 5 billion lab tests, vital signs. Another way I like to put it is we have everything from Tylenol to CAR T cells. Tylenol is probably the cheapest thing we can do to a patient. Give them a tablet of Tylenol. Of course, we're still going to charge them a lot. We're a health system, of course. All the way to CAR T cells, which means extracting their white blood cells, training them to fight cancer, and putting them back, right? That, I think, is the most expensive thing we can do to a patient. In other words, we got primary care, we got the most quaternary care there is, right? And everything in between. It's merged with California state regulatory data. We're working a lot with text. I could give you an hour-long talk on just text. We're getting pathology, radiology text. We actually conveniently run what's called the death index for the state of California. So anyone who dies in California, we have that as well. So that's all merged as an ultimate outcome. Constantly harmonizing elements, because even before we launched this, we had something called I2B2 and UC Rex, launched by Doug Bell and Lucille Ono Machado. So the teams talk monthly on all the new drugs that come out. We're constantly harmonizing all of that. So it's safe, respectful, regulatory, responsible use of clinical data. For those of you who are R aficionados, here's one line of code, a ggplot command, on the 24 million potassium measures. Pick one blood test. Here's 24 million potassiums here, right? Here's 6 million, 4 million, that's a y-axis. Literally one line of code in R gets you this kind of histogram. Luckily, most are on 4, some are near 0, some are at 8, those aren't so good. Let's make sure we did something right with those patients, but that gives you an example of just how many blood tests of everything we have in there. Now, before I go crazy telling you what we do with this data, I just want to make sure you all know we give this data to patients first. Patient empowerment is the most important thing we got to make sure we're doing with data, with interpretation, with all of our kind of data chops here. We give all of this data to patients in FHIR, and if you're health data aficionados, you should try this out, because the Apple Health logo looks like this on your iPhone if you have an iPhone. and you go to browse, and you go to add account, and you can literally add your health portal credentials, username and password, and zoop, all that data gets sucked into your iPhone. And if you get care at multiple institutions, all of it is in a single timeline. That already exists today. I know there are a lot of Silicon Valley types still arguing we should be doing this. You know, it's already on your phone. It's been there for like 2 or 3 years. UC was a launch partner with Apple on this. But if you just type in UC, you see all the UC campuses there. So we give all of that data to patients in federal standard FHIR format. Now, we also realized not everyone has an iPhone, right? It's a kind of expensive device. So UCSF now is partnered with Common Health to put this whole thing on Android. Because we were waiting too long for Google to do this. We said, you know, we got to just do this because patients need that. So same API, same SDK now exists on Android because we want to make sure patients are empowered first. So that's a no-brainer first thing. Okay, so this is what the patients look like. Here are the 7.5 million of them that live in this part of the country, right? Because Hawaiian patients, Las Vegas patients come from all over the world to get care from us. But you can, first of all, see each dot here is a zip code. Yes, this data starts as an identifiable database. Okay, we'll talk about that in a moment. So here's just the zip codes, which campus takes care of the patients. UCSF, UC Davis in the northern part, UCLA, UC Irvine, UC San Diego in the southern part of the state, and somewhere in there is a tiny little dot for Riverside with a couple thousand patients there. Now, of course, age, race, gender, primary care versus not primary care. We have, because we have their addresses, geocoded all 8 million patients based on their home address to the census tract, and from that, we can then get other indicators. So for example, the social vulnerability index, the area deprivation index are some big ones that people use. California has something called Healthy Places Index. We also generate that one. But from that latitude, longitude, we can figure out grocery store distance, what the unemployment is. That is just the tippy top of social determinants of health, right? I'm not saying we solved SDOH, but at least we know that for all of our patients. Now, there are a lot of edge cases. What is your home address when you are homeless, right? Every hospital does something different. Maybe there's a flag. Maybe you put the hospital's address. That doesn't help you when the hospital's in Santa Monica, okay? That's a nice place to live, but you're homeless there. So lots of edge cases. What do you do when you're rural? Well, you get your mail in a P.O. box. That P.O. box might be at a post office. That's not where you live. That's where the bill goes. So lots of edge cases trying to figure out even latitude, longitude of a house that we've had to work through. But we have that. Of course, who are the payers and all of that are there too. Now, in the past 3-4 years since we've had this, many operational teams have benefited from having this kind of data. I'm going to show you a couple examples. But population health management, managing costs, improving quality. Let me just show you a couple fun examples. So here's one of my favorites. This has to do with a drug called acetaminophen, Tylenol, is commonly known. But this is IV acetaminophen, so it's given in an intravenous. Now, a tablet of Tylenol, as you can imagine, is a fraction of a penny for us, okay, in the health system. A dose of IV acetaminophen is $50 a dose, and if you crack open the vial, you bought the whole vial, okay? So there might be legitimate uses for IV acetaminophen. Maybe you're trying to avoid opioids. Maybe it's a kid. And we give IV anything when you can't take things by mouth, okay? Maybe it's pre-op or post-op. But what we started to realize when we have a central database working with incredible pharmacy colleagues is we have so many patients getting IV acetaminophen at the same time as other pills. So why couldn't they just get the acetaminophen in a pill, right? Because it's $50 every single time, right? So we started an effort to just look at this. And because it's identifiable, we know the name of every single doctor writing every single order, every single chief resident, every single person, every nurse practitioner going back 11 years. Who's doing this, right? A lot of it's autopilot protocols, right? They're on this autopilot. Someone wrote an order set. Here's the IV acetaminophen. Now, again, I'm not saying there's not legitimate uses for this, but let's get rid of the ones where it was inappropriate. Now, and again, we can't just make dashboards. You got to work with the pharmacist to make this happen. Zoop, you can see it coming down here. Just this saves us millions in our health system. Just this pays for the whole database, okay? We got like 20 more of these we're working on. Just one drug. Why does it save you money? Because we're paid the same amount for each inpatient admission. Right? It's a DRG pre-negotiated. We're paid the same amount. If we do something stupid during that admission, the cost is on us. We don't get the bill separately for this drug. We're paid the same amount, We're super incentivized to find stuff like this and get rid of it if we don't need it. Saves us millions. Here's another one. This slide is deliberately blurry. Here are the top 10 drugs on every one of our 5 main campuses. So like, for example, this is UCSF. And this square here is a drug called pembrolizumab. It's used for cancer. It's a monoclonal antibody. And just to give you an idea, this entire slide is $3 billion. So this is how much $3 billion looks like. Top 10 drugs on each of our UC health campuses, our main 5 campuses here. Now, as you would guess, most of these blurry squares here, if you're talking about the most expensive drugs for patients that we send a bill out for, it's going to be monoclonal antibodies, right? But then why aren't they the same monoclonal antibodies? Like for anti-TNF-alpha, for example, we got, 7 choices now? Why does UCLA use this one and UCSF use that one? Which is the right one to use? Well, let's figure that out. Because now we're incentivized to do comparative effectiveness studies. I don't need a PCORI grant to do that. I want to do that now. Because once we have an answer, we buy the drugs together. Something Medicare is just learning how to do, right? So once we learn, we actually put in one purchase order to get the best price possible for these drugs and devices and knee joints and hip joints. Right? We buy all of those together in an effort that we call leveraging scale for value. You know why I'm showing you these business uses? Because there's this whole narrative that is so hard to get health systems to share data with each other, right? It's so much easier when you have a business reason to do it, right? And then, of course, the data is in one place for research, right? But it's already paid for itself when you got these operational things there. Now we got cancer. We got all of our NCI cancer centers in one cancer collaboration that we've been building out. We're doing trials together, though it's kicking and screaming, I admit. It's not easy. We have 100,000 active cancer center patients every year. Our best guess is that's probably triple to quadruple the #1 cancer center, right? MD Anderson down in Texas. But each one of us would be smaller. We know we are stronger when we work together. Find those collaborators that want to do business and research and clinical trials with you and use the data to make all the discussions happen. Now, by the way, we have all the cancer genomes in the same database, okay? So 32,000 cancers have been sequenced so far in the University of California. Whether it's Foundation Medicine or Tempus or in-house sequencing, we have all of that data in there too. So we know the pre-care, we know the sequence and the mutations, we know the post-care, we know the death, right? So for example, P53 is the #1 gene mutated in a UC sequence cancer, right? It's all in OMOP, which is the open data model here. The Korean team showed how to put this kind of data in OMOP. We just copy-pasted. That's how we have the cancer data in there too. All right, so where are we going next? We're really really following the playbook from the FDA. Look, I'm an NIH person. I still have to write papers and grants. I've had NIH funding for whatever, forever. It's amazing how much the FDA is inspiring us much more than NIH right now. Because of covers like this, right? Look at these covers here. Proposed regulatory framework for AI machine learning software as a medical device. FDA is telling us how to get AI and ML approved. Right? Real world evidence program. What we used to just call clinical data is now real world data, real world evidence. We'll talk about that. A digital health innovation plan, I think we are now past 20 prescribable apps today, right? These are apps on your phone or on your web browser that have passed clinical trials that you can write a prescription for now. And all of these are just in the past 5 years from the FDA, right? If we had even one of them, I'd be jumping for joy. We have all 3 now, really showing where this future is going for institutes like mine and yours here, okay? But let's talk about clinical data and real-world evidence. That is, I think, the best use of clinical data right now. Like you heard the CEO saying, we've spent so much money on these EHR systems. Are we getting our money's worth? Besides making life difficult for docs, let's use that data and try to prove what we can do with folks. Here's an example of just how real-world data is so voluminous. Take a commonly used drug like Humira. Humira is a great monoclonal antibody. It's been used forever. It might be coming off patent. There might be biosimilars now. But Humira, when it got approved for rheumatoid arthritis and inflammatory bowel disease, these were the 4 main studies. You can get this off their website. You know, the first study tested 500 folks with Humira. Then there was 600 in this trial, 299, 854. And based on these studies, they got FDA approval. And then boom, we've treated 11,000 patients already in the University of California, right? So drug companies have hundreds that they test with, and now we have tens of thousands using the drug. So I can get to start to ask really simple, stupid questions. Are all of my patients benefiting on Humira like they said they were supposed to in these trials, right? Why aren't we asking that question more and more? We should be testing every use of every drug and device and procedure we do against the standard, which is how they got their approval. And you know what? If our patients aren't benefiting as much, we should figure out why. And then we probably shouldn't pay as much for these drugs, right? And maybe we're the only pressure against drug pricing if we choose to look at our data. Because in general, we never look to see if our patients benefit like they did in these studies. We got to do that more. And now drugs are even getting approved strictly off of clinical data. The best example is Ibrance, which is a Pfizer drug for male breast cancer. I admit, not a lot of people get male breast cancer as well. It would take you forever to get a trial done. But this molecule was being used in female breast cancer, off-label use in male breast cancer. Enough clinical data existed that the FDA gave them an approval solely based on clinical data, no trial needed. That has now also happened with the Sapiens 3 artificial heart valve, maybe a dozen of these approvals now solely based on clinical data. With that, we launched in our institute a Center for Real-World Evidence, because we can see we're partnering with maybe 15, 20 pharma and biotechs now. They have questions, we have answers. We don't have to give them the data. We're going to work on the answer together, write papers about that, abstracts with them, and then they have new questions. And boy, this is a new model for us to work with pharma and biotechs because we have that data. We don't want to hand it over to them, but we actually want to get to the answers as well. And we've had a lot of successes. This is just a picture of one device. It's called the Cryosphere from a company called Atricure that our clinical data got approval for. No trial needed, actually, for this expansion. So it can be done, actually, with your own data here. Again, this is all since we started just 8 years ago. So lots of uses of data there. But the other big use of clinical data is now going to be artificial intelligence, machine learning. You've heard a lot of talk so far this morning about AI and machine learning. We're sitting a lot of data. I'm not saying this data is easy to use. A lot of it is unstructured in text. We're just going crazy now with text, right, with large language models and all the rest of those. But because the FDA put out this book and this cover, already 500 AI and ML algorithms have been FDA approved, most in just the last 3 years. 150 of them just in radiology. I'm going to tweet all these out at the end, so don't worry, but this is how you get to the actual lists. The American College of Radiology curates the radiology one. FDA has all the rest of those at their website. And what's interesting is you see the company column here. Let me tell you, it's a struggle to find even a single university on that list. Here we go again, okay? And what do I mean by that? Because if we're not innovating these, you know we're gonna have to buy them again someday. Why on earth are we not launching more of these with all of our data to get these through approval and into the hands of docs, including our own docs? There's really no excuse for it at this point, because we're sitting on all this data. We know the future's coming. We better not be ignoring that future, because this is what's happening. And this is actual exponential growth in approvals right now. Now, we haven't been sitting still. We've been doing a bunch of these partnerships with GE Healthcare. Now, if you buy the portable chest x-ray for your ICU, you know, patients can't get out of bed, so you need to bring an x-ray to them. If you buy a portable chest x-ray from GE, it will automatically call 2 emergency things. If there's a collapsed lung, a pneumothorax, or if the breathing tube is in the wrong place, it can't be too low, it can't be in one lung, it's gotta be up a little bit. Those 2 calls are made on the machine, trained by UCSF chest x-ray images. That was a partnership that is now 9 years old with GE, but that algorithm got FDA approval, started way back with UCSF images. It can be done. Now, any patient that gets that GE machine on them is benefiting from UCSF data like that, right? I better not be here in 5 years and not hearing a similar story from UW, okay? You're sitting on all this data. There's no reason this can't happen, all right? Otherwise, companies will go to someone else because they're coming to us for sure. Now, in the last few minutes, let me just talk about, where we go and what do we do with all this data and, what do we do next year. To me, I think the future is in AI and machine learning, but I think we're going to have the computer start to learn things by itself. So it's something what we call the deep learning healthcare system. So much of our healthcare system is still expert-driven, meaning I need an expert to say, I want to go study length of stay in this procedure, I want to go study outcomes in that procedure. But I think the computer is going to be sufficiently capable to just study everything simultaneously now, right? Once we code what the outcomes are, why are we waiting for an expert or a faculty member to say, go study this? I think the system's going to just constantly study itself and shoot out emails, maybe, or notification that we got to be improving this or that. But I think that's the future. But it's a complicated environment, as we've already heard so far this morning. There are biases in all of our data. It's not really the bias in our data, it's the bias in how we practice medicine, accurately captured with our data, right? The bias is way before we even collect the data. But biased medical algorithms, certainly well known now. I think we brought to the surface by Ziad Obermeyer and many others now at this point. GPT-3, of course, has biases. We're still, it's getting harder to find those biases, but they can still be found and kind of hacked in. Battle for ethical AI at NeurIPS and many other places. Last summer, HHS, Health and Human Services, passed this proposed rule to strengthen non-discrimination in healthcare, but this rule was all about algorithms, okay? So you need to ensure algorithms are not discriminating based on sex, race, ethnicity. Meanwhile, this went under the radar that our state attorney general sent a letter to 30 health systems saying, how are you as a purchaser of these algorithms ensuring you don't actually have this problem with race and ethnicity and bias like that? Now, you know how hard of a question that is? When we buy, let's say, a radiology algorithm, who actually manages that today in our health system, right? We don't have a chief AI officer, and I don't think the chief information officer does this either, right? So we're getting these algorithms right now, but no one's really making sure they're fine. They need to be stewarded a little bit more carefully. And then FDA over the fall said, well, sepsis tools are starting to get dangerous because papers came out showing the Epic one built into Epic that you can subscribe to was more often wrong than right. Within a week, Epic says, okay, we're overhauling this whole thing. We'll train it locally instead of having one global algorithm. And then just literally a month after that, the White House says blueprint for AI Bill of Rights, right? Everything I just showed you here is in the last 10 months, okay? It's absolutely this fast, it's this furious. This has to be a major part of what you're doing. This has to be a major component of your institute, okay? You cannot be behind on any of this. I think we need more transparency in develop and publish models, taking a kind of playbook from the molecular world where so much data is shared. We came up with this minimum information checklist now that a lot of people have signed on to. And I think we'll get more transparency in algorithms, how they were tested, how they were trained. But the inbounding of algorithms is going to get harder. Health systems are going to need to steward these algorithms to ensure they stay safe and fair. So think about it this way. When your hospital wants to put a new drug on formulary, what does that mean, formulary? You're allowed to write orders using that drug for your patients in the hospital, right? But what actually happens there? What happens is the chief pharmacy officer with the pharmacist say, we're going to monitor this drug for a year. Are there side effects? Is it being used appropriately? Is it being used for inappropriate uses? And for a whole year, they monitor that use for that drug to make sure it stays safe and efficacious, right? Why do they do it that way? It's because the Joint Commission makes hospitals do that. Otherwise, they don't get accredited. But for AI, we don't have a chief pharmacy officer. We have a chief nobody right now for this. And so I think we're going to need to think of that. And I would suggest borrowing, we wrote this in JAMA, borrowing from the pharma world how we put drugs on formulary, we should put them on digital formulary in some ways as well. Now, this might really blow you away. How does research data access actually work across UC Health? So like I said, we start with a fully identifiable database, right? And this is the UC-wide one, so it's mostly structured data. We're barely getting to notes. And then we have a legally de-identified. So it's a HIPAA 18 categories you strip out, no images, no text. And then anything in between is what HIPAA would call a HIPAA limited data set, right? So if you need zip code, if you need dates, you can always get a limited data set in the middle here. But this is legally de-identified. This is now so de-identified, all UC IRBs have signed off, it's non-human subjects research. So to get to any of this data within the University of California, you don't even need IRB approval anymore, okay? And you literally work on one campus first because we all have local OMOP, then you go to the global OMOP. And when you're ready to scale and authorize, we spin up a virtual machine for you. You sign a UC Health attestation. You promise to give us your firstborn child if you give this to a company, et cetera, right? So just because it's accessible doesn't mean it's open data, okay? Just because it's de-identified doesn't mean it's open data, okay? You can get to it. You can't give it away. R, Tableau, I don't know why I put R twice, Python, SQL. On cloud-enabled Databricks, it's kind of like a Jupyter Notebook, but Databricks is a Berkeley startup, so we're keeping it in the family there. Upload your scripts and run, but you cannot download data. Safe, respectful, regulated use of data. Now, I know there's my friends from AWS in the audience. This is how it is currently on Azure. It's moving, as they know. But literally, this is how it works. Databricks is Databricks. This is literally a query that I would write. Just go through all the different kinds of concepts for visits we have. And you could see, if you wanted to, you could train your AI on 93 million office visits, for example, right? And literally any UC faculty, staff, student, postdoc, grad student, trainee can get access to it with single sign-on credentials. But nobody outside of UC, because we can do nasty things to you if you do something nasty to us. If you're outside, you can't do any of that. So this is literally live and kicking right now, okay? No IRB needed. Get to that point, okay? You got it. That's what you should be aspiring to. And we're trying to get to safe, regulated enable UC researchers and patients to go beyond with machine learning in this safe, fair, equitable environment. All right, so what are we gonna do? What could we do with clinical data? I have 10 bullets here because I'm selling this story to 10 UC campuses constantly. I think clinical researchers are gonna go crazy with data. Mobile health researchers are gonna look at patients and contributing data. Community activists someday should be able to look at environmental factors for disease clusters. The cancer genomics researcher at UC Santa Cruz should be able to look at all the cancer genomes. Yes, this is David Hausler, for example. So we should have 10 bullets for all 10 of our campuses here. What am I gonna do with all this data? I'm gonna end with what I'm trying to do. I'm trying to build maps of death and disease in California. By the way, maps of death and disease kind of sounds morbid, but this is what I mean by maps. And I'm not using experts here. I'm using all of our data to tell us what happens to patients and what happens next. So Hannah J. did this work. We saw patients showing up in California with alcoholism, and a year later they show up with liver disease and cirrhosis, and year after that they have liver abscesses, or they go straight here. Each arrow is 1 year, and the squares mean you can die of those conditions. So it's really hard to die of alcoholism, easier to die of these side effects, right? Well, here's a more complicated map. We saw patients showing up with heart attacks, myocardial infarction. You can die right away, or a year later you have something called heart failure. Your heart is so weak as a pump, it can't pump the blood your body needs. You can die of that, or the liquid, the fluid backs up into your lungs, so you have lung disease a year later. And a year after that is sepsis. Now, sepsis is a body-wide bacterial infection. Why I thought that was interesting, now look, I admit I was trained as a pediatrician, didn't have a bunch of patients with heart attacks, on my words, but I always thought if you had a heart attack, I always thought it was the heart that killed you in the end. I'm amazed how many of our patients die of an infection in the end, just 3 years later. Because if you don't take the northern route on this map, you could take the southern route, kill your kidney, and end up with sepsis a year earlier here, right? And why this worries me is because I'm not even sure if we have a post-heart attack patient at home with a high fever, how super concerned are we about sepsis right now at that moment? I'm not really sure because it's a different kind of doctor than the cardiologist, right? And so maps can tell you what might be coming next and how to kind of prepare for that. But I love these maps, and I want to generate these maps, but I don't want to just kind of display the maps. I literally want to show where are all of our patients on the map right now. This is a prototype, but these are real Californians. As Californians age, this is literally how they go from disease to disease to disease to death. A whole bunch of them are going to get sepsis and die in a moment, and there they go. And it's okay, you can chuckle, okay? It's going to happen at some point for all of us. And now we can start to predict what's going to happen in the next 90 days, what's going to happen in the next year, and what are we going to do about it? And that, to me, is going to be the new definition of an accountable care organization, one that knows how to account for the care of all 9 million of its patients. And that is what I'm thrilled to be building with my friends and colleagues at the University of California. Can't do any of this with a long list of collaborations based at Stanford, UCSF, and NIH. An incredible team that pulls all this data every single month, every 2 weeks, and for COVID data every single night across the campuses. And I've been blessed with the endowment support from Priscilla and Mark Zuckerberg, naming gift from the Bakar Foundation, UCSF for their support. My lab has been blessed with 20 NIH grants from these 11 institutes of NIH. The ones in blue give me more money, the ones in orange give me less money, but I still love them. We have the governor's office giving us money for precision medicine, FDA. A lot of different groups have been funding my career over the past now 20 years. I thank my admin and tech staff. I'd never get a grant or paper out the door without them. And all the folks who have mentored me, hired me, and especially my family, that lets me go all over the world to give talks like this. Thank you very much.